Dr. Neeraj Nakarmi, and I am currently working as a project manager at MEDIC. I look after government partnerships and program implementations. I have more than 20 years of experience working in health sector. Okay, now talking about community health nursing program. In 2021, at the request of Nursing and Social Security Division, we started working on CHT app to support a new cadre of community health workers. The idea is to test the approach and draw lessons on deploying a trained and professionalized cadre of community health workers in the context where community volunteers have predominantly provided doorstep care. The community nurses are equipped with CST app and will provide doorstep care, conduct baseline studies, carry out health screening, and refer as appropriate. The program has already been launched and is in the pilot stage. The initial plan was to scale up after the pilot run, but given the interest shown by the local governments, NSST wants to deploy the program and the applications during the pilot phase. NSST envisions a comprehensive program and will be adding multiple use cases. In the next phase, NSST wants to add other use cases for screening, NCD, non-communicable diseases, mental health, geriatric issues, cervical cancer, breast cancer, and etc.
Hello, everyone. Namaste. I'm Lal Kuar from Nepal. So I'm a service designer since last 3 years. Yeah, I'm working in the field of public health close 2 decades. Yeah. So yeah, without delay, I'm going to present the hierarchy and the users of this NSST project. So at the ward level, ward means here the administrative unit of a government. So at the ward level, there are community health nurses. Community health nurses so who deliver the service at household level by using of these CST tools, so which is known as here CHS app, community health information system app. So at the municipality level, there is a CHO, which means community health officer, so basically who oversee and manage the community health nurses. They verify the report of a community health nurses, and if there is any error things happen, they corrected it. So you guys can also see the upper the district, so we have also created the hierarchy for a district public health officer at district level. Similarly, for the provincial level for the public health administrator, we have also created the hierarchy for the director at a central level for the NSST. So this is because this is for we kept on the mind for the future. So if the program is for the keeping in mind the growth of a program in the future. So just also we are planning to design a analytical dashboard or something else for this tire. So we have created this hierarchy. So far, one CHO, one community health officer oversee 10 to 15 community health nurses, and one community health nurses 8 to 15,000 households currently so far there's. So I'm going to here talk about the use cases of an NSSD project. Yeah, already Neeraj mentioned few points about this. So at the beginning of a program, we designed and implemented the baseline along with the RMNCS users case. So through the baseline, we captured. We captured the basic information about community at the household level. So which includes the education status of a population, non-communicable disease burden in the community, uh, nutrition status of under 5 children, immunization status of under 2 children. So it is we gathered a lot of basic information from the community. We designed that way, and after along with the baseline survey, we also implemented the RMNCS use cases. So where we designed reproductive maternal neonatal child health stuff. So it includes the pregnancy surveillance to pregnancy registration, pregnancy home visit, delivery, family planning, these stuff. And in a next phase, we are already in a designing and the configuration phase for the cancer screening for breast and the cervical cancer screening from similarly for the mental health. Similarly, we are also designing a non-communicable disease stuff. So in a left, you can see in the workflow. If we talk about, if we talk, we are going. If we talk the workflow of NSSD, so it's pretty simple. So community health nurses are equipped with the tablet and which is installed the CSIS app. So they do the routine home visit each single home of their community and try to identify a complication, high risk cases, and they made refer. So if they made the refer, it trigger for the task. And on the basis of a task, CSM again visit the that particular beneficiary or patient and ensure the facility visit and prognosis of a disease and counseling for them accordingly. Yeah. So if we talk about the details, so this is the piloted from the NSST side. So far, it is implemented only 3 municipalities with 42 users. So among them, 3 are community health officers and 39 are community health nurses. And the NSSD has a plan that after this piloted project, they have a plan to implement it robustly in other municipalities and districts. So the here in the left side, you guys can see the outlooks of our CSIS app.
Let me start the literal meaning of Sunni Ek computing. So what Sunni Ek is actually. So Sunni Ek is the Nepali name. Sunni means 0 and Ek means 1. So we are the binary company, Sunni Ek computing. So that's the literal meaning of Sunni Ek. Sunni Ek is the healthcare information technology, which is profit not distributing company, which closely works with government, non EDPs, local governance, policymakers, universities, and researchers. We started our journey back in 2021, January. So far, to this stage, our major engagement is around the CHT implementation and support researchers, which is being carried out from different entities, which includes universities, mostly local governance and non-profit organizations. So as an entity, as an organization, we are very strongly vocal on utilizing the technology which is open source. So as a part of that initiative, we are the member of the technical working group at the Ministry of Health, where MEDIC is also there, and we are very happy to be along with MEDIC in this mission. So since then, we accomplished few of the projects, which I'm going to mention in the other slide. This is the one. This is 2 different use cases that we have where we have used CST. One of the tasks that we got is from Kathmandu Metropolitan City, where we had been provided as the delivery for baseline survey where CST will be used and is already into the field. So for now, the plan is to collect the baseline information, and then gradually the CST will be connected with facility-based care, where OpenMRS is being implemented, which is not started yet, but in the radar, we are the implementing partner for the OpenMRS. So that's why I think it's worthwhile to mention both of the technologies, because that's the radar that we have envisioned for. The second one is the RCT, randomized control trial, which is the part of the research from University of Penn State, for which we have selected the 1,000 household. Since this is RCT, which is being carried out under the control and treatment group, for which we have split the demographics into half, which is around 500 household. 500 household for control group and 500 for treatment group. So total number of users for this intervention is this resource is 18, which is itself the nurses, where we have trained them to use and to collect the information, which is itself the household level. And total ward, which is included under this study, is 40 wards. Per ward, there are 24 randomized household. So which is again the randomized one. The major milestone that we got after the successfully establishment of Sunni is our old partner. I'm saying old here because I used to work at Possible Health previously. So there is some story around this. So previously we used to have the SaaS model mobile health platform, which was a bit costly for the organization for Possible Health. So we had planned to migrate back in 2018-19. That's the time when I met Michael. So since then, eventually, that what we had envisioned got succeeded at after the establishment of Sunni, after I got offboarded from Possible, and which is back in 2021. And for this whole activity, from SaaS-based paid system to locally owned CHT platform, was around 9 months of total engagement, which includes 12 implementer as well as the developer. So during this transition time, we had got the opportunity to work with with Kashmir University, which was huge learning in terms of acceptance of the technology. The main reluctancy for us was since the system was already running with one other platform, and it was really challenge for us to intact the data post migration. So that was challenge because historically there was around 6 years of community health program data. So that was pretty challenging, but eventually that happened, and now since January 2023, already around 44 users are using, which includes CHN and CSW. So total population enrolled with the system is 115,642. Total family enrolled is 32,479, and 33,044 is the total household enrolled. So you can see the picture where how the program has been designed itself, not only related to the tech, but also coordinating with the local healthcare units, where CVM NCI undertook balanced counseling, group ANC, so home-based antenatal and postnatal care, and continuous surveillance are the activities that is being carried out at the community level. This is one of the training that we initiated post-migration. That was the part of the implementation. So all of these CHNs and CSWs are using CHT, and we got this opportunity to take the feedback from the CSW, where they mentioned the system is pretty easy to use and is easy to follow up, as previously the technology that what we were supporting was not capable enough to handle the task and targets and everything. So for now, the reason CST has that capability, users are really happy. So that was the feedback from CST itself. So this is something being a bit techy, but we're really happy to work with Medic Mover and the community health toolkit ecosystem, since we are also the part of that now. And we strongly follow the open source community, since we are into the practice of this. There are a few of the wish lists that we would like to see. One is the form designer. So let's make it easy so that our non-techie implementers at the ground level can easily adopt the system and scale in the larger implementation. APM is something that we can talk with tech team. So application performance monitoring, we can raise this in other tech discussion. But basically, if that comes up with the out-of-the-box solution, would be easy, so that we don't have to invest in the paid system. And data dictionary for Nepal based implementation. Let's say if Medic or we can initiate this, then we can share that dictionary for other mobile health platform build as well. But that will be remained as the standard data dictionary for ML platform. That what we are doing right now. And hackathon, we have already discussed with Medic team as well and CST team. This is something that is really important for strengthening the community. Nepal is very in the early stage of building the open source community, and I feel such activities will bring out those people who are interested from academics as well as from the professional side. And the last one is the out-of-the-box analytics. This is something that has been requested by our implementation sites as well. They really want to have the out-of-the-box analytics so that they can easily interpret the data without depending with the tech guy like us. So this is something that we have gathered as a feedback from users as well. And I think this is this much for now. I'm very happy to answer the questions related to the presentation. Thank you, everyone.
So we'll leave the floor open for any questions that anybody may have regarding the community story presented by Dr. Neeraj, Lal, and Sanjay.
Thank you very much for very interesting implementation and story. I just wanted to find out if one, you had challenges with the rollout of the solution, especially on the CHW end. Did you provide phones? Did they use their own phones? Were there challenges with the usage of their phones as the data grows? Or any other challenge that you face? Thank you.
Thank you for the questions. Yeah, as I said, in Nepal, CHN program is in pilot stage. We just started. So yeah, they are providing phone. We are collecting data, and we are giving service on tablet. Yeah, sometimes it's become slow, but yeah, it's everything government procure. If something happens, they replace. So we don't feel any problems till now. But as I said, it's in pilot stage. It's a 3 years project, so it's very early to say challenges and now. Thank you.